So, is it helpful to calculate how much the femoral neck anteversion is preoperatively for dysplastic hips? So that you can dial in that amount of version in the SROM neck. So, and how do you do it?
It is very helpful to know in advance about the version of the cup and the anti-version of the femoral neck. Why is so? Like in grade 1 and grade 2, it is not much of a difference. So you can manage easily. But in grade 3 and grade 4, you need to fix your cup, not taking care of the alignment, version alignment, but you have to fix the cup in inclination of around 45 degrees, but taking the maximum contact of the bone. So we are too careful about the version, but even then we have to know.
So I'm talking about neck version.
Neck version.
Femoral neck, so that we dial in the stem.
Yeah, neck version is important. If it is more, then we need to do osteotomy, subtrochanteric osteotomy. Like if it is more than 60 degrees. It is a must to do trochanteric osteotomy, but if it is less than this can be managed very well with the SROM implant.
So
the modular stump.
Yes, I mean CT scan gives a very good idea, and if we know beforehand, then we can have a backup of modular implants. We can plan osteotomy to reduce.
So why I'm asking is this, because in Delhi every implant is available. We ask the company people to arrange SROM for us. और सर 15 दिन रुकना पड़ेगा अभी कुछ सूरत से आ रहा है कुछ so if you know what amount of anti-version, if it's not too much, we can put in a different implant, and you don't have to wait.
You're talking of other implants.
Yeah.
You can have Wagner cone, small cone. You can use cemented. Depu has a very good cemented short stem.
But if the version needs to be adjusted, we'll have to wait for SROM implant.
No, besides SROM, you can use cemented also. A cemented stem. What stops you from using cemented stem? You can dial in any direction. And they have CDH cemented stem.
Cemented stem can accommodate to an extent the
subtrochanteric osteotomy. We generally
and if you have to do osteotomy, then cemented stem
if it is 60-70, then this different story. Then you will have to wait. There is no other
way. We have
way.
serious problems arranging the SROM implant.
Oh yes, it has to be there. And one question, one of the speakers spoke nicely on fused hips, and I think you talked about double dome osteotomy, 2 osteotomies in the neck. Any other method to be very careful not to break the calcar? Means while doing an osteotomy, if you don't do double osteotomy, any other method you can guide us that instead of double osteotomy, we can do other way around to get the neck cut in situ in a fused hip so that the calcar is not broken.
And these are very poor quality bone.
If you do an incomplete osteotomy and your assistant tends to rotate, the fracture goes right down into the calcar.
Can do, sir. It can do at the mid-cervical level, but because you will get in this way, you get a little space for the rimming.
So you strongly advise only double dome osteotomy.
It is better to go for because we get more space after that for the acetabular rimming.
And sometimes it's a difficult combination that has gone in and it is fused. Very little space available between the trochanter and acetabular margin. Then you cannot go all the way with the saw. One has to take a precaution. One can use drill bit and drill on the inner side. Drill the calcar area. Try to use an osteotomy. If not, still, you are sure that even if your assistant rotates and you are doing an osteotomy, it will not go down because you have made stress risers on the medial side. That's one practical tip we have observed.
And this is a very, ankylosing there, the bone quality is very bad.
The bone quality is bad. I think one of the most complex hip sessions.
So, thank you, the speakers, the panelists and the chairperson. A quick photograph and then we move on to the next session.
And because of the crunch of time, by the time these pics are being taken, may I invite upon the stage the chairpersons of the next session, Managing Unconventional Hip by THR. Dr. Satpal Sisodia, sir. Please come on the stage. Dr. Gaurav Upadhyay. To moderate this session, may I call upon the stage Dr. Ajay Bharti, Dr. Uttam Garg, sir.
Call upon Dr. Dharmendra Kumar for his talk.
Everyone, respected chairperson. I'm going to present a case solving a failed total hip replacement, a complex revision arthroplasty in patient with acetabular fracture. This elderly patient presented to us at a 4 weeks old acetabular fracture. This is a preoperative X-ray showing that transverse fracture of acetabulum, breaking the both iliopectineal and ilioischial line, along with distorted acetabulum. To further explore the anatomy of this fracture, we have done this X-ray, this CT scan showing the fracture of the anterior column, quadrilateral plate, and the posterior column with posterior wall. So basically, this is transverse with T type of fracture. And it was initially managed with posterior approach, along with the acetabular reconstruction done with the posterior approach, with the posterior column plating and uncemented THR. On the acetabular side, uncemented multi-hole cup used, porous cup used. On the femoral side, uncemented proximally coated femoral stem used. So post-operatively, patient was advised for bedridden for sake of instability of the implant, and post-operatively also developed serous discharge. This was managed with longer antibiotic and the wound dressing, and infection was subsided. And this patient remained bedridden for 6 months. Then again presented to us this picture like this, along with inability to walk. So the key issues in this case that like bone defect and medial migration of the acetabular cup would compromise the intrapelvic vessel. So we need to get a CT angio, along with the hip dislocation, along with the proximal altered anatomy of the proximal part of the femur. So we need to do the planning to achieve the stable implant, and the goal of this management of this case is to long-term survival of the implant and good functional outcome. So before going to the treatment part, I would like to present some review literature. If the total hip replacement done for the acute acetabular fracture, so risk of dislocation is high, approximately 15%, and risk of revision surgery is high, it is approximately 18%. And this paper is published in Journal of Arthroplasty. Again, another paper published in the Journal of Arthroplasty, they also suggest that risk of dislocation and revision rate is high if you done the total hip replacement in acute acetabular fracture. And this another paper published in Journal of European Journal of Orthopedic Surgery and Traumatology. They also suggest that lower functional outcome and risk of the high risk of heterotrophic ossificans in if the total hip replacement done in the acute setting. So coming on to the case, so for surgical planning, we get done the CT scan. This is 3D CT scan showing the fracture is still not united, along with disturbed anatomy of the acetabular cup. So, and this patient was managed with posterior same skin incision. Then we remove the acetabular cup and look for the stability of the column. And we put the allograft, and we use the BS cage with posterior libbed liner. So this was a intraoperative finding. After removal of the cup, we look for the stability, column stability. We find that instable anterior and posterior column. and cavity is curettage, and then allograft is put, then impaction grafting done. And then we put the BS cage and for attached to the superior part of the dome and posterior column of the sternum. Then we put cemented cup, and again the proximal part of femur is maluniting, so again wiring of the greater trochanter done. And intraoperative stability of the implant check and found satisfactory. And then this is a post-op X-ray, and this is follow-up at 3 months. This is final 1 year follow-up. Patient is having good radiological and good functional outcome. So conclusion of this talk, you don't jump the acute total hip replacement in fresh fracture unless it is indicated. And if you are doing, then you assess the column stability first, because the cup stability is dependent on the integrity of the column. And when there is a doubtful integrity of the column, then we need to put a bone graft and use the cage, preferably the BS cage or cup cage construct. Thank you. Any questions?
We will have the question session later on. So kindly take your seat. And I request Dr. Pankaj Valecha. Is he here? Please.
Good afternoon, panel. Good afternoon, everybody. Does having extra bone in osteophytes form or in a fused hip form throw your plans out of the way, and you're always worried that, well, will I be able to put my socket in a predictable fashion? If that is the case, then you are not alone. In the initial few cases, me and my assistant will always discuss, is the anti-version enough? Thoda aur badhaएं या thoda aur घटाएं? But in this talk, I'll try to discuss few basic things which are very, very helpful to avoid such scenarios. Transverse acetabular ligament and pulvinar are the two most common and most predictable anatomical landmarks we all should identify, whether it is a fused hip or it is a hip filled with osteophytes. Let me start with a very basic case. We have discussed a lot of complex situations since morning. Now, in such a case where you go in and have a medial osteophyte, it is very, very counterintuitive for you to think that when I have to take away this medial osteophyte, I have to actually ream vertical. So when you're reaming the medial osteophyte, your assistant is wondering what you're going to do if you ream such an open fashion. But when we ream that and when we identify the pulvinar, it really helps you in navigating, and it really helps you in reaching at the right spot. Because if we don't know where we are going, we'll not reach there. And then the medial wall concerns. I did a questionnaire with my fellows, and the commonest things which came out was, I'm always worried if I go too medial while I'm reaming. So when you're reaming, with the reamer, we always feel how the bone quality is, whether my bone is feeling good or the bone is osteoporotic. We also know by clinical history. We also know by looking at the x-rays and by the history of the patient, whether it is a neck femur fracture or it is a osteoarthritic hip. And then you ream and go up to the medial wall. In every single case, and there's a study by Beverland, in 97% of the cases, you can identify TAL, you can identify pulvinar. So in this particular patient, I was just showing that pulvinar, we could identify that by reaming the medial osteophyte. Other thing which was being discussed is the high hip center, which has been covered very well. In cases where you have oblong socket and the superior inferior dimension is bigger than the anterior posterior dimension, you try to inferiorize your reamer and you always find some space there. But if you're not eating away the columns significantly, you can go with a big cup. So in this particular patient, this is the post-op, we had put a 58 cup. But we made sure that the columns have not been destroyed. And also there was a discussion about how to identify if your hip has been raised high enough to affect your longevity. If your inferior margin of the cup is not higher than the teardrop, in the post-op X-ray, you are at a good spot. Because sometimes we need to superiorize the cup a little bit to get the reduction, especially in tight hips. And if you know if the bone is weak, you ream less. If the bone is too much, like in septic arthritis, equally you ream a little bit more, and you try to go as close to the teardrop as possible. And if there are too many osteophytes, still if you look for pulvinar and if you look for TAL, you'll reach there. Now, another scenario which was discussed, fused spine and a mobile hip in an Angst patient, which is a common scenario in our practice. When you go in and you do, the first thing you should do is to do X-ray of pelvis with both hips in standing position. Because when we do that, we see the obturator foramens. If the obturator foramens are open, just like in this case, we know that this patient has excessive posterior pelvic tilt. And that was confirmed when you do the spine X-ray in sitting and standing. There is no change in the sacral slope in the first X-ray which is done in sitting and the second which is done in standing. In such cases, you have to make some compensation. Of course, we will discuss and we can discuss and debate how much compensation is to be made. But if such is the scenario where spine is fused, but hip has fibrous ankylosis, some compensation has to be made. You identify the TAL just like we have done in this case. And then you put your cup in relative retroversion. Sometimes in complex situations, you have to do counterintuitive things. But you have to know where you are going. If you don't have TAL, then you are just guessing. This is the post-op X-ray after a bilateral THR for this patient, 2-year follow-up. No dual mobility used for this patient. At the same time, fused hip and mobile spine. We do not need to make any compensation here. This patient, when the hip gets mobile, he's a normal guy. You can see the sacral slope has changed significantly in standing and sitting. And in the first, we are doing in situ reaming because this is bony fusion. There was also a discussion about how to identify. Of course, you cannot identify in every case, but you can find labrum in many cases. You can find after the in situ neck cut, you can find the inferior edge of the neck, which guides you where the inferior edge is. And when you ream through it, you find pulvinar. When you find pulvinar, if you go have a little bit courage to ream that inferior thing, you will find the TAL like you can see in the third video. And once that is done, you are able to create a stable hip with well-maintained offsets. I've used 2 different types of stems here. We can discuss why I used it in my next talk. Thank you very much. Yeah, thank you very much. When we talk about neck length and when we talk about stems, we've been discussing about S-Rome stem and different types of stems. We know that there are certain situations where we require different types of stem. And does the neck length matter? Do we need to use them for offset management? I also overheard offset management being discussed when I arrived this morning. We know that number of patients are rising, younger patients are there, and their demands are increasing. And not every hip looks the same. Some hips have coxa vara, some hips have coxa valga, some have shorter neck, some have septic arthritis, equally high riding trochanter, hard to bring them down. In a common scenario, when you're using only one type of stem, you will either try to cut neck more or you'll try to sink in your stem. But one size, you may fit, being an orthopedic surgeon, we can fit anything anywhere, but the patient may not feel good about it. I'm a regular corail stem user, and all these varieties of the corail stem, which is collarless, collared standard offset, short neck, coxa vara, and long stem, or S-Rome. Everything has a place, every stem has a place. In last 2 years, 40 patients, we ended up putting a small short neck stem and coxa vara in 18. Although standard offset collarless was the majority, in majority of the cases we use that and still remains the workhorse. What we need to understand before we get into it is the offset change when you go from a standard offset to a short neck. If you go from a standard offset stem to a short neck, you are dropping your medial offset by 5 millimeters on an average. You can see this in this chart. And you are losing neck length by 7 millimeters, which is consistent. Why the offset is variable? Because the width of the stem is changing, which goes in. If it is a little bit wider, the center of the axis of the stem changes, and that changes your offset. So when you are doing that, or when you are using a coxa vara stem in a patient who is 6 feet 4 inches tall, where you have already achieved the neck length, but you are not able to achieve the medial offset. In that patient, coxa vara stem can be very helpful, but remember, coxa vara stem drops your neck length by 5 millimeters, and if it does that, you have to use a +5 or a +8 head for that particular patient. That's the only juggler you need to understand. In this particular patient who is a bony fused, simple protrusio right side, complex protrusio on the opposite side, has a very short neck. And we need to make some compensation here, minor compensation. Let me give you a basic thing which we use. If the sacral slope change is less than 10 degrees, or if there is no change, you need to make major compensation. If the difference is 10 to 20 degree, then you need to make minor compensation. If there is no difference, or if it is more than 20 degree, if there is more than 20 degree or there is a significant difference, no compensation is required. How much compensation we are doing, then experience comes into play, which was being told by Dr. Arora this morning and also by Dr. Kumar. So in this particular patient who had complete bony fusion, was finding it very hard to walk. This is a video showing the technique of in situ osteotomy. I'll just, I have time. So you can do it in multiple ways. You can either use a saw if the hip is not fused in external rotation. If hip is in severe external rotation, you may have to go from the front. But if hip has some space, then you can go with a saw from posterior, or you can do a wafer osteotomy of the overhanging posterior margin of the greater trochanter. Once you have done that, in many patients, you can identify with your cautery pencil a space between the acetabular socket and the head. If you just burn your cautery, start coagulating, you will find that margin. And then again, I have found pulvinar here. And then we used a special stem for this particular patient. This is a short neck stem. And this is a technique where we are doing in situ reaming. And in situ reaming, you know, I'm trying to inferiorize so that I don't run into the posterior superior aspect of the socket. And eventually you find pulvinar, you find TAL, and you're able to go there. In 3% patients, we are not able to find pulvinar, or you're not able to find TAL. If you have been doing it for 97% of the cases, you will know where you are. Of course, that's why the technology has some space here, but without discussing that, we could build up the medial wall in this patient. If I had to put a standard offset stem, I will medialize my cup, because otherwise I'll jack up the offsets or I'll increase the leg length. But I have built up the medial wall in this patient while using a short neck stem on both sides. We used a screw, we used screws on the other side because it was a complex protrusio. Whenever the protrusio is superior and medial, it is a good idea even after a build-up you put screws. But if it is only a medial protrusio, you can go out without putting it if you are sure about your fixation. Another patient, bilateral angstpond, small offset, thin lady, weak bones. I ended up cracking the calcar on right side, but I used a short neck, and I could, if I take you back into the picture, I could recreate her offsets. And multiple such scenarios. In this particular bilateral avian patient who was an engineering student and son of a doctor who works in stem cell research himself, this engineering student, 22 years old, wanted to do everything. I did his one hip and went in to do the second hip. Of course, while we are doing the acetabular preparation, I don't know how deep I have gone into the socket. You can see my right side socket is slightly, I have more bone on the medial side. So I ended up, for the same neck cut, I ended up lengthening with the standard offset, and I used a short neck, and I could bail myself out with 3 to 4 millimeters of lengthening. And same for this bilateral bony fused guy, not very significant offsets, needed some compensation, totally fused, could do a short neck, low offset stem. So it is not only that I'm using it for collar, this stem is available with collar because of the biomechanical reasons. And even if there are multiple papers, if there is a few millimeters of gap between your calcar and collar, it is okay. We are doing a study on our cases on one of the parameters is collar calcar distance, and does it affect the sinking of the stem in the initial phase. So it helps me in fine-tuning the limb length and offsets. It builds more bone for the future, and in many cases, less is more. Thank you very much.
So may I request Dr. L. Tomar for his presentation.
Good afternoon, everyone. Thank you, organizers, for this opportunity. And again, my talk is on single-stage bilateral total hip arthroplasty. This is both hip replacement surgeries in single anesthesia setting. So it is gaining popularity due to potential economic and clinical benefits. Sir John Chanley in 1971 presented 50 cases of single-stage surgery. There were several studies published with variable results. Leonardo et al. In 2003 showed increased patient satisfaction with bilateral hip procedures with no increased risk. So this is 38 years old patient with bilateral fused hips, ankylosis with fixed spinal deformity, operated, however, ASA grade 3 operated for bilateral single-stage surgery with uncemented implants. So another patient, 55 years old male patient, bilateral AVNA with secondary osteoarthritis, difficult to walk, and was very confused whether he'll be able to walk with both hip replacement done in the same stage. So was operated in the same stage, and you can see, can we achieve the optimal outcomes without compromising safety of the patient? They're able to walk within 48 hours of the surgery. So various pathologies, bilateral hip involvement for the total hip replacement. So roadmap to single stage is choose your patients wisely, surgical approach of your surgeon's preference, set protocols, dedicated expert team in high volume center, and key to success is minimizing operative time and optimizing the patient recovery. Inclusion criteria for this procedure, good functional baseline, ASA grade 1, 2, well-controlled comorbidities, and the exclusion criteria is cardiac instability with pulmonary and renal dysfunctions. Pre-op optimization is critical for the success for this procedure, and patients with ASA grade 3 and grade 4 are with higher complication risk in single-stage surgery. Implant selection is very important. Uncemented implants with larger head preferred for this single-stage surgery. The earlier reports in 2008 and 2009 JBJS showed cost efficiency, similar mortality rates, same complication rate, but longer hospital stay and high blood transfusion with single-stage surgery. However, these are modifiable risk factors. Higher initial blood loss can be minimized with tranexamic exit use and hypotensive anesthesia. Thromboembolism risk can be controlled with good prophylaxis. Cardiopulmonary strain, particularly patients with pre-existing conditions, can be managed with uncemented implants, and infection risk can be mitigated with careful surgical techniques. So these are the advancement THA which make it easier for single-stage surgery. And single-stage surgery, the studies show that there is hospital stays down by 27%, average length of stays 5 days, hospital cost is down by 28%, and there are no clear disadvantages with single-stage surgery. There are this is cost-effective, has very well been established, and psychological benefits are there. And this is crossed out to dysplasia hip. In 40 years male patient operated both simultaneously with uncemented hip. Another patient, 48 years male with psoriatic arthritis, single-stage surgery. 54 years male, AV and with secondary osteoarthritis, single-stage surgery with uncemented implant. So single-stage surgery gives more symmetric weight distribution. There is better hip range of movements, functional improvement is there, and there is early resumption of activities or daily living. Direct anterior approach has better early outcomes in the form of pain and relief, and perioperative fluoroscopy can be done, but there is long learning curve. But there are equitable results with all approaches. All approaches, whether it is posterior or the lateral approaches, can be done. The controversies with single stage are that high risk of complications are there is a myth, and studies show no significant increase with proper protocols, and outcomes are comparable in carefully selected patient. The patient risk benefit analysis showed complication rates are comparable to stage total hip replacement, and functional outcomes are even better with single stage bilateral hips surgeries. The evidence is based on 2019, 2020, 2021 studies consistently show comparable safety and superior cost effectiveness of single stage procedure with proper protocols. And in a meta-analysis of 64,000 cases showed fewer major complications with single-stage surgery, as published in Journal of Arthroplasty in 2017. So our results in 512 patients, age ranged from 20 to 70 years. The average blood transfusion was less than 5 and complication rate were less than 1 degree. The first case we operated of single stage surgery was in 2002. This was a young female, and the right hip was replaced, right hip was revised 18 years after. The other hip is still surviving. So, a few examples that the crowd type 2 achondroplasia in a 27 years patient operated with single stage bilateral hip uncemented implants, ankylosing arthritis, 55 years male implant with cemented bilateral cemented hips, 61 years old patient arthritis, single stage surgery with uncemented hips, and this is 8 years follow up. So, and then the report, one report of 3 cases has been published with single stage surgery in an ambulatory setting. So, current evidence in single stage surgery showed improved satisfaction, patient satisfaction, however, selection is paramount importance. So, to conclude, with proper patient selection and a systematic approach, single stage can be safe, efficient and transformative procedure, and let's continue to refine our strategies and push the boundaries of what is possible in arthroplasty. Thank you very much for the patient hearing.
Wonderful, sir. Please have your seat. Dr. Shweta Rai.